I wanted to talk about something that's near and dear to my heart, and it's the idea of the utilization of local treatment, be it radiation, surgery, or any other modality in the management of metastatic patients. And the real idea is, are we trying to identify, or can we identify a subset of patients who will actually benefit from local therapies, not just for palliation, but actually for survival benefits? These are my disclosures. And so, as we all know, at the end of the day, as we try to personalize our therapies to optimize treatment of our metastatic non-small cell lung cancer patients, biology is really the prime driver. And as you can see from this laundry list of things, we are getting a much better understanding of the biology of non-small cell lung cancer and realize that it's a very heterogeneous disease. But one of the things that I wanted to bring up that's in red is that whether we can determine and use the idea of patients who only met out in limited number of sites versus those who met out more widely as another biologic surrogate for us to be potentially aggressive or use a different treatment paradigm. Why is all of this even possible? This is all possible because of the great work that has been conducted by our medical oncology colleagues to improve systemic therapies. So clearly, the introduction and utilization of immunotherapy with or without chemotherapy has improved our outcomes, but clearly we can do more because the curves can get much better with respect to progression-free survival and overall survival. But without a good systemic therapy, there would really be no role for local therapy. And so that's really the rationale for the use of local treatments, local again being radiation, surgery, ablation, for the treatment of metastatic disease. Systemic therapies have gotten more widespread. They've gotten better, but they are not perfect and really cannot stand alone. And with better imaging, the question is, can we identify a subset of these patients who don't metastasize widely as a chronic or curable subset of patients? Additional rationale for using local therapy is the fact that most patients do respond to their first-line systemic therapy, whether it's chemo, immunotherapy, immunochemo. And the problem is that that's not an as durable response as we would hope. Historically, with chemotherapy, progression would occur after 3, 4, 5 months. We've certainly improved that with IO-based therapy. But the other important aspect of this is that most failures, when they do occur, and most first failures occur in sites of original gross disease. So that was known and established by the University of Colorado group a number of years ago, that the original sites of disease that a patient has at diagnosis and at recurrence, the original sites would be the sites of recurrence. But the question is, do we get a similar pattern of failure with immunotherapy? So we set out to do an experiment or study where we looked at about 118 patients who were treated with systemic therapy alone, primarily a pembrolizumab-based immunotherapy. Out of those 118 patients, 71 recurred within the period of time that we analyzed. And when we looked at the patterns of failure, what we found was that in that table 2 on the topmost part, most failures, about 84% of failures, included original sites that existed at the time of diagnosis. So again, when patients fail immunotherapy, they appear to be failing where they first had disease. And you can see the other kind of information about the pattern and the distribution of failures. But what was also very striking to us is that when you look at the third area, oligoprogression versus systemic progression, at least half the patients only failed in 3 or 5 or fewer sites of metastatic disease, whereas the other half failed more widely. So it again gave us some promise that even in the era of immunotherapy, there are a large number of patients that are not failing widely, but failing in a limited fashion, again, providing us with the impetus to consider local therapy. When you look at, and it's a small subset of patients in this retrospective analysis, but when you look at survival as a function of progression or no progression, it's very obvious. Those patients who progressed had the worst survival, and the ones who progressed the earliest had the worst survival. On the top left graph, on the top right graph, you can see that those patients with oligoprogressive disease, or the ones that failed in a limited fashion, did have improved survival. We are going back and looking at those patients to see how many of them actually received local therapy and how many did not. When you look at the bottom left, patterns of failure, again, survival was worse when there was both an evidence of local and distant failure. And then at the bottom right, when you look at survival as a function of whether the failure was in a new, existing, or both disease sites, the patients that developed new failures ended up having the best survival. So again, the idea that local failures are important to control is a meaningful one.